Nobel Prize final. Well, good afternoon again. Welcome to NUWAY University Counseling Center. Welcome to all of you joining online. I know there's a lot of things going on and a lot of places you could all be, so thank you for being here with us today. Huge thanks to all the folks at YourPath. Dr. Delisi, thrilled to have you presenting today. Very excited to have you all here. My name is Jake Lewis. I'm a Senior Community Relations Manager here at NUWAY Alliance, and I have a few housekeeping things. But before I go over those, I just want to give a brief overview of NUWAY. NUWAY has been a nonprofit since 1966. Today, we have 5 medium intensity residential programs. 3 of those programs are in South Minneapolis, and then we also have a medium intensity residential program that serves female identifying clients in Rochester. And then we also have Cochrane Recovery Services, which serves male identifying clients, and that's in Maplewood. It's a new location, so if you have not been to Cochrane Recovery Services, please let us know. We'd be happy to set up a tour or show you around. It's a beautiful new building in Maplewood, and excited about that. And then we also have 7 intensive outpatient with recovery resident support programs. 2 of those are in St. Paul here, or excuse me, 1 in St. Paul, and we have 2 in Minneapolis. And then we have a program in Duluth called Duluth NUWAY Counseling Center, also in St. Cloud, Mankato, and Rochester. All of our programming are co-occurring, supportive of medication-assisted treatment, and supportive of LGBTQI+ individuals. And just really excited to be able to provide extended care services to the community. We also have a outpatient continuing care program, so that's ASAM 1.0, and that's here in St. Paul, but most of the folks involved in that program are joining virtually, so that's a good option. And then we also have 2 new programs, Aragoni East and Aragoni West, which provide housing support with some supplemental services. If anybody would ever like a tour or more information about that, please feel free to reach out and let us know. We're happy to accommodate that. A couple of housekeeping items. For those of you joining virtually, please make sure to enter your name and email in the chat. That's how CEUs will be sent out. CEUs will be sent on Friday, June 14th. So just a few days from now, it's the 14th. Yes, Friday is the 14th. They'll be sent out on Friday. If anybody here in the room would like a tour of this building afterwards, please feel free to stick around and we can take you around and show you the building. And then we're excited to not only host today's presentation, but a follow-up presentation combined on August 21st. It is the co-occurring ABCs. Our Chief Clinical Officer, Ken Roberts, will be presenting on that. I will share the link shortly with folks virtually so that you can get registered if you're interested. And then folks here, there's some flyers and information you can take about that program as well. So again, thank you to Dr. Delisi. Thank you to the folks at YourPath. We're super excited to do this 2-part series, one today and then one again on August 21st. I would now like to turn it over to my good friend Jordan Hansen, who can talk a little bit about YourPath and then introduce Dr. Delisi. Jordan, take it away.
Thanks, Jake. It's good to see everybody. I'm Jordan. I'm one of the co-founders and the CEO of YourPath. We started YourPath about 3 years ago, and the goal was to make it as easy as absolutely possible when people need help, whenever they reach out. What would it look like to make it as easy as possible? What would it look like if we lived in a community where accessing recovery supports, person-centered recovery supports, was as easy as accessing substances? We started in a barn. It was a very nice barn. It had Wi-Fi and like a heater, but it was a barn. It was 3 of us, and we were experimenting to see what we could do and if this would work. And over time, we've tried to maintain that commitment to accessibility, believing that if we work collaboratively, we can be so much stronger together than we are just as like point solutions and little dots. And I'm thrilled to be able to introduce Dr. Delisi. Steve and I have known each other for a long time now. I was actually his student, and then I was his TA in grad school, and then we practiced together in the residential setting and outpatient setting, and then so anyways, I've seen this presentation like 25 times, and I told our team today, I'm like, you got to come, it's really great. I'm excited to see it again. But Steve has been a champion for truly integrated care, and as a person in long-term recovery, what's almost as important is the humility and the spirit with which he practices. Very rarely do we meet physicians who have a humility and it's not a respect even, it's like a reverence for the recovery experience. And this is the thing I love about Steve is we're going to learn a lot about neurobiology. I wouldn't be shocked if the Sicilian comes out in Steve and he's given us the hand gestures around this, but also the humanity of that. So we really appreciate all the folks that are here today, all the work that you do, all the partnership that you give us. I also want to put in a plug. If there's anything that we can do to be useful to you or the people you serve, we want to do that. We are by no means perfect, but we pride ourselves on trying to be responsive and taking suggestions. We're nothing if not moldable. So without further ado, I'll turn it over to Steve Delisi. Thank you.
Well, thank you both for the wonderful introductions, and it's great to be here. Want to just do a sound check. Do we have good sound virtually? Jessica is monitoring that, so I'm hoping that we got good sound. And then in the room, if I talk like this, you can hear all the way back. All right. I usually project just fine, so there is that. So again, I'm Steve. I am by training a psychiatrist and addiction medicine physician. Been in the field 20 plus years, spanning Chicago, La Crosse, Wisconsin, and then now Minnesota. I've been with YourPath for the past year. As Jordan mentioned, our paths have been crossing and crisscrossing for many moons. What he didn't mention is that then he transitioned from student, TA, colleague to boss. So he has been inspiring me for the past several years and gives me an opportunity as an old doc, 20 years plus in the practice, to pivot from working where people had to navigate a complex, convoluted, make no sense system, to me, to work for an organization that's trying to get treatment to the people. And that feels really good. I will say my why of doing these presentations is the using science to reduce stigma. I will get reductionistic. We're going to talk brain regions. I am going to gesticulate. I get super excited about all of this, but it is fundamentally grounded in our humanness and our interactions with one another. I will make the point repeatedly, we are hardwired and designed to be in fellowship with each other. And that's the point that I will be making. And so I'm going to start, this is just my disclosure, blah, 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 all the things I can't say no, so I say yes too frequently. Learning objectives, we're going to start by talking a little bit, just 2 slides on stigma related to use disorders. Then I'm going to talk about substance use disorder as a chronic illness. For many people, not everybody has a chronic illness when they have SUD. Sometimes it is time limited and there's natural recovery, right? But for a lot of the people and most that come and get in contact with treatment, they have a chronic variant of the illness we call substance use disorder. So what is chronic illness? We'll spend a little bit of time on that. Then we'll do a bit of a deeper dive on substance use disorder as a neurobiology. And I'll also talk about the 3 primary reinforcers that are most important in understanding why individuals use and why they continue in their use despite negative consequences. And then I will finish with setting the stage for my partner in this 2-part series. Ken is going to come back in August, as you heard, and he's going to unpack, like, with all of this science And with the intersection of co-occurring disorders and adverse childhood experiences and trauma with substance use disorder, like now what do we do with that information? So I'm going to leave you with a lot of questions today to make you come back on August 21st to hear some of the answers. Fair enough? Okay. So we're going to start with bias and stigma. And when we think about what is undergirding the stigma of substance use disorders, we can expand that to think about and talk about what is the biases that sit under our judgment and our stigmatization of many chronic illnesses. It's not just substance use disorder. And I'll show that in a couple of slides, but substance use disorder definitely fits into this. And again, it's one of my core central whys to be doing this presentation. The first core bias is what we term the cause bias. So as we have a belief that the person had intentional cause of the condition that they have, we tend to judge and stigmatize. So if the person with a substance use disorder, with a person with addiction, if they just hadn't picked up, right? Like, was anybody holding them hostage, telling them they had to use that first time? And when we have that view, when we have that thought, we can start to believe that there's an intentionality and a participation in the development of that condition. And it tends to drive up stigmatization. The second core bias is control. And when we have a belief that someone should have control over certain behaviors that may contribute to an illness, we again infer judgment and stigmatization. What does that look like? Like, how is that lived out? Well, it can be lived out in this sentence here. This comes directly from a journal article by Dr. John Kelly, who's been a champion of language and stigma within substance use disorder, as well as a champion around recovery and recovery capital. And in one of the publications, I color-coded this. The statement was, they found a way to get drugs. Why can't they find their way to get treatment? And it's color-coded. They found a way to get drugs. That's cause. They're causing it. They're finding the drugs. They continue to find the drugs. And then control, they should have control and see that this is a problem and seek treatment rather than the drugs. Does that make sense to people? We'll unpack it further as we move along, but I just wanted to start there. This slide starts to give a sense of that there's also kind of a hierarchy of stigma and judgment. On the far left is low perceived cause, low perceived control, something like pediatric cancer, right? We tend not to stigmatize and judge kids with cancer. Make sense? But as we move to the right, as we imply more cause and control, we do start to stigmatize. Stigmatization is not solely in the realm of substance use disorder. Individuals with heart disease, high blood pressure, diabetes, HIV, obesity, depression, anxiety, all stigmatized. Because there's a sense that, well, if you just had lived a different way, if you had just done X or Y, or not done X or Y, this wouldn't be happening to you. Making sense? And on the far end are things like a heroin use disorder, methamphetamine use disorder, especially if we start to talk about IV drug use. One subpopulation that I have seen to be amongst the highest stigmatized are pregnant women using drugs. Extremely high judgment and stigmatization, far into this. We can quibble in terms of where I put some of this from left to right. The one part, though, that I don't want to quibble with, and I want to point out is prescription opioid use disorder, heroin use disorder. Are those actual disorders? Do we have different DSM diagnoses of that, the clinicians in the room with me? Or is there a common diagnosis that would be given to those? Yell it out. F11. Now, opioid use disorder, love it. We're going right to the code, nailed it. So opioid use disorder, they're both opioid use disorder. They're not different in their diagnosis, but there's most definitely a difference in the judgment and stigmatization at the societal level. And again, around cause and control. Is that resonating with people? So as we dig into understanding the science of the brain part of this illness, and as we start to unpack the overlap between what reward pathways in the brain are hardwired to do and how that is impacted by childhood adversity and trauma, we start to poke holes in those cause and control biases. That's the whole roadmap of our time together. Making sense to people? Okay. So let's pivot and talk about features of chronic illness. So if I'm going to say that most of the individuals who are coming into treatment and navigating the chaos, the 10% to 15% that get an actual evidence-based substance use disorder treatment in the United States, that's about what the percent is. The rest are not getting treatment. That 10 to 15%, they most frequently truly have a chronic variant of this illness. And so it shares other features of other chronic illnesses like high blood pressure, diabetes, heart disease, and the like. And what are those features? This is one model that I think does a good job of unpacking it. And the first is complex causality with multiple factors leading to the onset. Like it's not just you got this one gene and now you've got the illness, but there's genetics, there's epigenetics that we'll talk about. There are environmental impacts, right? There are psychological factors, all kind of coming into the picture to develop the chronic illness. So that's number one. I think substance use disorder definitely fits that. We haven't found the gene of substance use, and we're not going to. There is not one gene for this, period, end of story. Number two, long development period for which there may be no symptoms or what we call subsyndromal, like under the table symptoms. Now, in substance use disorder, we often can see and hear an individual who says, from the very first moment that I used X, I had a problem, like 0 to 100, no middle ground. But many other histories, as we listen to the person, we can hear the harbingers, the early symptoms of a substance use disorder early on and over several years. And you can even hear it before the person ever picks up a substance, if we're listening for it. Number three, prolonged course of illness that can have other health consequences, right? So if somebody has high blood pressure, it's not well managed, it goes on for a long period of time, there can be consequences to that. Same with substance use disorder. I think any of us who are working in this field see the other health manifestations of this chronic illness, yes? And then finally, two last, associated functional impairment and disability. By definition, substance use disorder is a functional impairment and disability, and we'll talk about some of the cognitive impairments when under this illness. And then finally, we're not often finding cure, and there's relapse and long-term management that's needed. I'll unpack that term relapse in just a moment. I did not change it on this slide because this is not my model, and I wanted to hold true to the Australian health and welfare. But we're going to take a look at that term relapse because that term, when used by healthcare professionals in any ilk, perpetuates the cause and control bias. And we'll talk about that in just a moment. The next three slides that I have are of the seminal study by Tom McClellan way back now in 2000. None of this is new. In 2000, McClellan's team said, this is ridiculous. We are not addressing substance use disorder as chronic. We're trying to treat it with one episode of treatment, and then magically the person is to be in lifelong recovery. We need to be looking at this with a lifelong management to have the best outcomes. And so they embarked on a seminal study where they compared substance use disorder to things like high blood pressure, diabetes, and asthma. So HTN is shorthand for high blood pressure. Okay. And the first thing they looked at was how genetic is it? And what they saw was it was the same as all other chronic illnesses. This is kind of the take home on this slide is 40 to 60% of your risk of any chronic illness is from what you got from your parents, biological parents. And the other 40 to 60% is what happened to you through your life. That is almost universal along chronic illnesses. Second one was adherence rates. And here I start to tweak the language. If you look at this study, they're going to talk about compliance rates because that was the language of 2000, right? We had the program. We knew exactly what's going to get you well, and you either do or do not comply with it, right? Now we've moved more and more towards shared decision-making and a person's centered approach. And that way we're developing a more person-centered and individualized treatment plan that they will partner and adhere to because they are aligned to it. That's very different than complying with it. Very dumb. I'm seeing some nodding. Here, the big bias was, and still is, people with substance use disorder do not adhere to their treatment. They don't follow, in quotes, the program, right? Right? What McClellan's team found is that's actually true, and some of the lowest adherence rates are, in fact, in addiction, as low as 20%. That's pretty freaking low. But they also found that some of the highest rates out there are for substance use disorder. There's a lot more variability. The difference in colors, I should have explained this. The difference in colors in these bar graphs is the variability across the studies that they were researching. So there was a variability. So anywhere from 20% adherence rates to as high as 60% adherence rates when looking in the field of substance use disorder. Diabetes, anywhere from 40% to 60% and a bit lower for high blood pressure and asthma. What is the take-home message of this slide? Humans are horrible at adhering to treatment plans, especially when you have to do it for a long period of time. I don't know if anybody has been on antibiotics for a sinus infection. Often you are on amoxicillin 3 times a day for 10 days, literally just 10 days, a week and a half. They've actually done studies. Almost no one gets all 30 doses in as prescribed. So if we can't do it for 10 days, what are we doing with chronic illness? So the expectation that we need to have is that we're, the health professionals, we're responsible for keeping people engaged, motivated, and re-engaged. And we should expect some lack of adherence and look at how do we improve adherence. That make sense? Finally, comparisons of recurrence rates. And here I changed the language. I know Tom, I trust that he is okay with me not calling it relapse rates. Because in their study, when they looked at, in quotes, relapse rates for SUD, diabetes, high blood pressure, and asthma, they defined a, in quotes, relapse as the reemergence or the recurrence of symptoms severe enough to warrant a change in treatment. And when you study it in that way, look at the results. Substance use disorder reemerges in a very similar rate as other chronic illnesses. Again, take home, if we're treating people with chronic illness, it's not going to be start treatment asymptomatic for the rest of the treatment. But historically in this field, we have had that expectation. Historically in my career, I've had that expectation. You're now in treatment. No more use. No more use ever again. That's literally asking the person at day 1 of treatment to be asymptomatic. We don't do that with someone who has high blood pressure. If I'm starting medications on someone who has high blood pressure, I'm expecting that it's going to take several months to get that stabilized. And by the way, once stabilized, I'm not talking about quickly taking them off the medications like we often do for individuals with alcohol or opioid use disorder. Oh, well, you're stable now. Now we'll take you off the medications that were part of what helped you get stable, right? That makes sense? So this one's a really important one because again, we have in the mindset and our health system 100% has this in their view that substance use disorder reoccurs far more frequently than other, in quotes, medical illnesses. That belief is held most tightly in the emergency room. And I'm not throwing shade on my emergency room colleagues. It's that they're in the trenches of seeing what it looks like to have a chronic illness not well treated. And so if you don't treat the person with evidence-based practices longitudinally, things do not go well. As a medical student, this will date me. I'm so old that when I was in medical school, we did not have chronic disease management for diabetes, which meant that when I did my peripheral vascular rotation, that's studying people who have diseases of the circulation of their limbs, most of that 12 weeks was helping in amputations. And 100% of the people smoked cigarettes, and almost all of them had poorly treated diabetes. Anyone with diabetes in this room, we do it way better, but take your management seriously because controlling it well makes a big difference. And we've made huge strides. We've driven down cancers. We've driven down heart disease. We've driven down the stroke rates with high blood pressure, and we've improved asthma and diabetes significantly. We have not seen the same thing with our field. Just a few, 2017, 70,000 overdoses. Now we're celebrating only 107,000 because it's level. That's not a good outcome. And it's being driven by this stigma, these biases. All right. So we've talked about cause and control. We've spoken about substance use disorder being more similar than different. And when I say chronic illness, and I'm up here as the physician, I am not saying that the solution to this is a medical solution with medications. That is not what I am saying here. I'm saying that we have a condition that has a physiologic, and we're going to start talking about that biology, that does need a biopsychosocial and spiritual approach. All of those are true. So I want to make very clear because sometimes people hear me get going and it's like, oh, well, so the idea is you would just send them to the doc and they prescribe a medication. That is not exactly what I'm talking about. That's not true of any of the chronic illnesses. You don't treat diabetes just with a pill. You don't trust high blood pressure just with a medication. You don't treat depression, recurrent major depression, just with a pill. You can, but the best outcomes are when you take a biopsychosocial perspective and you treat the whole human being, because we're not just our biology. All right, so let's go in. Before we go to biology, I want to go to recognizing primary reinforcing properties. So like what makes these substances, in quotes, addictive? Well, they all share, and we'll look at in a moment, they share the ability to activate the dopaminergic system within the reward system. That reward pathway, though, is not a pleasure center. That is a take home for this afternoon. I don't want to hear anybody talking about the pleasure center and that dopamine is the feel-good neurotransmitter. No, that is a false perception that keeps being spewed. The reward pathway is there to signal what is most important in my environment for my well-being and my survival. We all have it. It's all hardwired in. And things that get triggering that system are then signaled as we got to pick up what just happened because this is important to repeat and sustain for our well-being and our survival. Sometimes it's pleasurable, but it's not the key element. Okay? So when we think about what are the reinforcers that might lead to the activation of this system, I'll lead with the one that we get stuck on, and that is euphoria. That the person does feel better, right? How do I get at this? I will ask, tell me the story about the first 1 or 2 times that you used X, Y, or Z. And I want to hear the first couple of times, because that's where you're going to get the primary reinforcement. It is not downstream. Downstream, you most often are, I just use to not get sick. I'm just using because if I don't use, I'm sick and I'm sick and tired of being sick and tired, right? But at the beginning, the first couple uses, that's different. And so what I might hear is, I felt awesome. I felt better than I'd ever felt in my entire life. I had more energy. I could do all things. It was incredible. I've been chasing that my whole rest of my life, right? That gets squarely put in the euphoric bucket. But that is not the totality of humans' interaction with addictive substances. In fact, that is the fleeting one. Much more often and much more at the core are the next two. And so in answer to that question, I might have someone say, yeah, I felt better, but really, I felt an inner peace. I felt calm. I didn't hurt. That overwhelming sense of doom and dread was taken away, albeit for a moment, but it was taken away. Or my chronic headaches, my chronic back pain, my knee pains finally went away. It could be physical pain. It could be psychic, emotional pain. It's the moderation, the reduction of pain that's important critically for our survival and our well-being. In this bucket, I'm also listening for someone to say, when I first used, I felt like I could just sit still in my own skin. I could just be me. That's really important because that's communicating something is fundamentally distressing about being them or sitting in their own space. And the drugs or the alcohol temporarily took that away. Might quiet the thoughts, the memories, the images, the nightmares of prior trauma and abuse. That goes in this bucket. The last thing that I'm listening for is when someone says that when they used, it made them feel normal for the first time. Heard that? It's the only time that I felt normal. You got to unpack normal because we're humans. I've not met a normal person yet. So I want to understand, what does normal mean to them? And that tends to overlap both that the normal often is that something distressing, something that made them other than, was temporarily taken away. But that starts to cross over into the third, and I think one of the most core reinforcers that unfortunately the addictive substances usurp and hijack, and that is human attachment. Human attachment, of course, has a psychology, a sociology, a spirituality. You can't distill human connection and attachment just to brain science, but there is a brain science. And human attachment and connection is critically important. Here, I'm listening for the person to say, the first few times that I used, or when I have a return to use, I have an overwhelming sense of belonging or connection that I don't experience any other time. Or a sense of warmth that just kind of envelopes me. Or, and really profound, when people will tell you that heavy drinking or using their substance actually makes them feel as if they're hugged or embraced. Why? Because the neurobiology of human attachment and connection, two of the most important chemicals are oxytocin, the love hormone. You hear about that when mom has given birth and is breastfeeding. Mom's brain is bathed in oxytocin. Baby's brain is bathed in oxytocin. When any of us as adults are gazing into a baby who can now make eye contact, I can assure you both brains are releasing oxytocin in that moment. Anyone in the room have a dog? Human canine, this brings home the importance of this system for survival and well-being. Canines and humans did not start out as friendly partners in life, right? We have evolved together because it's mutually beneficial for our survival and well-being. And one of the things that happened along that evolutionary streak is that when you are gazing into the eyes of your little puppy dog with their eyes, your brain is bathed in oxytocin and the dog's brain is releasing oxytocin. Isn't that fascinating? It's amazing. And then you couple it with touch, human touch. That triggers our endorphins, our own brain's opioids. And that enhances that sense of connection, attachment, and connection. And unfortunately, heavy binge drinking and many of the addictive substances like opioids activate the opioid system and mimic that. And so when someone says that it's as if they're embraced and hugged, that is profound language because they're literally saying what's happening in the brain. And that's when our brain regions that we're going to look at now kick in and they send out powerful signals to say, this is the most important thing that you have experienced for your survival and well-being, not the most important thing to feel good. That's not this system. This system is a drive for survival. And why is attachment and connections inextricably linked? I'm telling you, oxytocin and the opioids are all over this reward system. They're all over the front part of the brain that we're going to talk about in a moment. And it's like, well, why is that? Why? Because humans not adapted well for life on Earth. We stink. We're not the fastest. We're not the strongest. We will not survive unless we do it together. Period. Just think about any one of you who is a parent. It takes a freaking long time to raise the kids to the point where they can live on their own. Any parents in this room, was parenting a blissful, amazing experience 24/7, 365? No. For those of you who are not yet parents, sorry, that's what's waiting for you if you are going to be a parent. But we've all been kids. And I ask the same question. As a kid growing up, was living with your family and dealing with your parents and your siblings blissful every moment of every day? No, it was a torturesome experience for many of us. But it's triggered, and that connection is infinitely important. And then we get to choose our family as well. And as we choose our family, that becomes family. So that's what's important. And so now let's unpack, how does that happen in the brain? Like when something that's important to feeling better and having less pain or attachment, what's happening at the brain area? Well, first of all, I'm going to introduce Amy, because if I don't do this, I'm going to do this quick so that we've got a little bit more time for questions. But I want to anchor to a person. Amy was someone who came into treatment. She's a real person. She was using IV and smoke form fentanyl. At other times, she would just use whatever pills she could find on the street. It was literally anything, everything, every day, don't want to be sick, right? And she came into treatment post-hospitalization for a non-fatal overdose, right? We've also learned that this was a pattern. It wasn't a one-off. She'd been in and out of the emergency department, seeing people nodding. We all have our Amy's in our head. That's the point, is I'm sharing this quickly. You start thinking about your Amy's, right? So that we can understand what's in their brain within active addiction. So there were frequent non-fatal overdoses. There was also self-injurious behaviors in the form of cutting. We also learned that she has a history of depression and anxiety. She is first prescribed opioids because of nondescript pelvic pain. So a pain in the pelvic region. Workup was all negative. There was nothing that we could find that was the cause of the pain. Depression, anxiety, she had been on multiple different medications back to age 16. Our first glimmer of adverse childhood experiences as a child Both parents had depression, both parents had substance use disorder, and there was physical and emotional abuse in the family. So we already know that her ACEs score is a 4. I will tell you, for purposes of the end of my presentation, her ACEs score is actually a 7. And as she came to trust us, not shockingly, there was a significant sexual trauma history, which then started to shed light on the whole pelvic pain, right? The body holding that trauma and then communicating in a way that she could not. The good news is that she followed up with mental health. She started in SUD treatment. She's going to see psychiatrists down the road, and she's open to consider meeting with an addiction doc. Little cautionary note: she's currently unemployed, living with a significant other, and that significant other drinks and smokes cannabis daily. She also had, as we got to learn more, alcohol and cannabis use disorders. So we're not going to talk about how cannabis differs from opioids or alcohol differs from methamphetamine. That's important. They don't work in the brain and the body the same. But there are some common pathways that overlap, which is part of why you most frequently see multiple use disorders rather than one isolated use disorder, because they're all sharing the pathways that we're going to be talking about. And these are the pathways we're going to talk about. Don't freak. Really the end result is that I want you to know that in the middle of the brain is where that reward survival mechanism is at. And then the very front part of the brain, what we call the prefrontal cortex, that's hardwired to regulate the limbic system. And when the limbic system, that middle part of the brain, kind of is unregulated, we have more risk of addiction, and we have more risk of co-occurring mental health disorders as well. So let's step through substance use. So at the beginning, there is the first step is that acute intoxication, and that's getting at that acute reward, like what's happening in that moment. And so that is where there's dopamine. And the dopamine system is monitoring and trying to figure out what's important to survival. Let's pay attention here. And when something important comes along, dopamine is released and it's triggered as a reward. But again, reward doesn't mean feel good. Reward means this is important to survival. This is a system in the middle part of the brain. Sometimes when I'm talking with patients, I'll say your brain is like a fist, and the thumb is the limbic system where survival and emotions and drive are, and around the thumb is the rest of the brain, the cortex. And at the very front is our executive control. That part of the brain, this front part is telling the thumb, hey, chill out. Like, not the most important thing to your survival, kind of a false signal. Let's not go there. That's front part of the brain, okay? The middle part of the brain doesn't have those thoughts. There is no rational cognitive thought in there. Any of you who do dialectical behavioral therapy, emotion mind, reasonable rational mind. And when they're in balance, it's wise mind, right? So limbic system, instinct, drive, and survival. That part of the brain, more and faster dopamine is more important. That's the signal. More, faster, important. And so if we look at some relative dopamine release, at baseline, just to get going in the day, we all had about 50 units of dopamine circulating in this reward center of the brain, just to get us up and going. We got to get motivated to get out of bed. Agreed? So that's kind of the baseline. If you were dragging today, maybe you were sitting at 30. And if you jumped out of bed, maybe you were sitting at 60. If you enjoyed the snacks in the back, or for those listening online, if you had a good meal, and especially if you had a meal with friends or family, now you're bumping up to 70, 80 units. With physical intimacy, with sex, we bump to 100 to 150. So 2 to 3 times baseline, important to survival, right? And going to be reinforced. Heroin, 800. Methamphetamine, almost 1,200. There's the hijack, because those are more and faster. It's also why heroin and fentanyl are more rewarding, reinforcing than something like methadone or buprenorphine, which activate much slower and for a longer period of time rather than the spike of heroin or fentanyl. Because this part of the brain isn't looking for something that's at a steady state. It's looking for the spikes. Does that make sense? And that makes a big difference between a drug and a medication. If that was the whole story, then anyone who is exposed to an intoxicant would have a huge risk of a use disorder. And fortunately, the vast majority of people, humans, who are exposed to an intoxicant do not actually develop a use disorder. Why? Well, it may be that we have differences in the whole dopamine system, and the reward system is different. And we'll look at that when we look at ACEs and trauma. But it also is often that this signal of the prefrontal cortex, the front part, that's saying false signal, not real, not important to survival, it's blocked. Or if there was a serious and significant trauma history, there's been a delay in its development. And so then all that is left is the limbic response. There isn't that signal to say stop. There's just the go, go, go. So even with the first use, even before the first use, that choice, that control, that cause is not equally distributed across our population. And for us to judge someone else in that state does not do the other person justice. We have to also be careful with when we're working with someone who is seeking treatment, what is their capacity to change? Like, what can they do? This gets at that compliance adherence thing. If I expect Amy to follow through with all aspects of the treatment plan that I am thinking of right after being in the emergency department with an overdose, do we think that's going to be successful? No, that is not assessing her capacity to change. And some of you are like, say, what? How the hell am I going to assess if this person is capable of change? Here's your signal. This is what you're looking for if you're sitting with Amy to determine how much of that front part of the brain, how much of that executive function, how much of this is able to control the thumb. And that is that when we see someone who is not objectively able to assess themselves or the situation, they have poor judgment across multiple domains. They have an inability to learn from past experiences. So like this whole thing about consequences, it's fundamentally a misunderstanding of the brain. That statement, they found drugs, why can't they find treatment? This is the why. Because the limbic system ain't looking for treatment. The limbic system is looking for what it learned is the most important thing to survival. When the person seeks treatment, even in an imperfect way, it's our opportunity to say, hey, you got more of your brain on the line. Way to go. That's recovery right there. Let's build on that. That makes sense? That makes sense? The other thing is poor attention span, argumentative, thin-skinned, self-centered, disorganized. I put those in a different color because they're stigmatizing, right? Those are judgments, right? But it's important because if you're anything like me, you tend, when you're with Amy, to start feeling like you're walking on eggshells. Like if I don't say the right thing, if I don't do the right thing at the right time, and everybody around them is feeling that same way, like it's just going to explode. That's a really good sign that you've got someone who's struggling with their prefrontal cortex. And it's not special to substance use disorder. You can totally see this with individuals that we will diagnose something like borderline personality. Same thing. Neurobiologically, we're seeing the same thing. They've got in that moment and in that time, there is an executive functioning deficit. The frontal part of the brain is just a bit disconnected. And we have to assess that. That's why the rules around treatment settings can be helpful because it's an external prefrontal cortex. And sometimes people need that at the beginning. We also need to check our own reactions, and I need to check the time. We need to check our own reactions because when I'm with Amy and she's being argumentative, thin-skinned, and I'm getting frustrated, I'll show that. I'll be frustrated, I'll be irritated, I'll feel less hopeful about Amy, right? And here's where the language comes in. If I'm seeing her have recurrent returns to use with reemergence of that symptom of her opioid use disorder, and I start to call her a chronic relapser, I've ceased to see her as a person. And when I say that the person relapsed on opioids, who's the action connected to? If I say Amy relapsed with opioids, who's responsible for the relapse in that sentence? If you're dissecting the sentence, who's connected to the verb relapsed?
Amy.
Amy. So I've literally reinforced the cause and control biases because she is in fact the cause of the relapse, as compared to saying to Amy that she has had a reemergence of symptoms of her severe opioid use disorder as evidenced by her return to use. Now the action is on the severe opioid use disorder. That fundamentally changed how I practiced as a physician in this field. Because prior to that, all of my Amy's were frustrating, irritating, and chronic relapsers. And I wasn't a good clinician for them. That was not serving them well. As we continue to use, I'm going to go a little more quickly in these next couple slides. As Amy continues to use and use and use and use, we all know about the tolerance that you build up and you got to use more than you had to use before to get the same effect. What's going on there? You're making less dopamine receptors. Those dopamine receptors are less sensitive. Now you're making less dopamine, and now your baseline is just blah. This is that person who is in early recovery and is like, man, I feel like crapola. If this is recovery, I don't want it. This is where you can do science and say, listen, this isn't your new baseline. You're feeling like crapola because you've got low dopamine in this part of the brain. It's going to come back. It's okay. And we can show pictures like this that show that it's not theory. That after a month of using cocaine, there is less dopamine. Less red and orange means less of those receptors. It's like, this is real hard science of how it works. Then if the person is out and not in treatment and not having their withdrawal managed, they go into withdrawal if they stop using, right? And now we've got even more profound reductions in dopamine, and we start to get the activation of the amygdala. AM is amygdala. And that's the part of the brain that is emotionally laden memories, fight, flight, or freeze response. That's the seat of many of our emotions. And so we've got a lot of negative angst and emotion and difficulty. Plus, we have all of the other physiologic symptoms with the changes in blood pressure and heart rate and sweating and not sleeping and tremorousness, right? And so then the brain is like, we're literally not surviving. This is not going well for us. And the amygdala is sitting right next to the nucleus accumbens and kind of kicks on the nucleus accumbens and says, we're not going to survive this. And the nucleus accumbens wakes up and says, oh, not a problem. I remember that when dopamine gets flooded into me, because that's what happens. Remember, the nucleus accumbens is where the dopamine is. I remember that's when we used. So now we have that withdrawal mediated return to use and craving. Making sense? We can also have it that something terrible happens in our life or a major stressor occurs and the amygdala flares into fight, flight, or freeze from that life stressor. And then it kicks on the nucleus accumbens and says, we're not going to survive this. And the nucleus accumbens again kicks right in and says, use. We're going to use. And now that's the emotion cue induced cravings and return to use. That's what's happening at the brain level. And how is that happening? Like, what's happening in that moment when we're fully aware in the one moment that we don't ever want to use again. And in the next moment, we don't even realize it and we've used, right? What the hell, right? This is what the hell. Instead of the front part of the brain controlling our emotions and controlling that nucleus accumbens to say, that ain't the way to survive. Getting back into treatment, connecting with your fellowship and your friends and your family, that's how you survive. That doesn't happen. It's an insidious, horrific role reversal in this often critically chronic illness where those arrows go in the other direction. Why don't they seek treatment? Because the nucleus accumbens and the amygdala are telling the frontal lobe, hey, problem solver, get on this and solve where, when, how, and whom are we going to use next. That's how the brain works in a substance use disorder. And when you look at it that's a very different cause and control than sitting there and contemplating and choosing in a conscious way. Just a quick brief, because then I do want to hit ACEs, and we're at 254. I thought first that I was going to be super clever and treat Amy with a medication called naltrexone, which is Vivitrol, which blocks the opioid receptors, works for opioids, works for alcohol, works for self-injurious behaviors. I'm the wisest, smartest person ever in this field. Completely negating any assessment of her capacity to change and to cope and tolerate with the intensity of that early recovery period. And she didn't tolerate it at all. She didn't tolerate the medication. She got severely depressed. Her anxiety went through the roof. Cravings were beyond compare. There was more returns to use, another non-fatal over. It was a complete disaster. One of the ways I think we can most effectively teach is to teach from our failures, or I shouldn't say failure, when we fall short of where we would like to have been. And so then we pivoted and we worked with a partial activator of the opioid system, the buprenorphine, the active ingredient in something like Suboxone, and she did very, very well. In addition to working with an individual mental health professional, and we put her in formal dialectical behavioral therapy. All of that together helped significantly. All right, so let's finish just a quick dive into ACEs trauma to set up Ken, and then he'll go into more detail. And the reason that I want to tag on to this here is because this is a real interface. There was a fairly recent study of women seeking treatment for substance use disorder, and the number of individuals in that group who had 4 or more adverse childhood experiences, and that's the inflection point. If you have 4 or more ACEs, that's where you see increases across all chronic illness, substance use disorder, depression, suicide, but also lung, heart, liver disease. Of women seeking treatment for substance use disorder, 84% of them had 4 or more adverse childhood experiences. In the general population, it sits somewhere around 15 to 20% that have 4 or more. These are just the 10 initial adverse childhood experiences. So abuse, physical, sexual abuse, neglect, physical and emotional neglect, and household challenges, domestic violence, substance use, mental health disorder in the family, separation, divorce, loss, or household member being incarcerated. I've shown this in many different presentations. Just in brief, the reason I love this is it shows that the tree are the 10 to 13 common ACEs. We've now added homelessness, bullying, up into a lot of the ACEs surveys. And Ken is going to be understanding the ACEs surveys. But those ACEs survey items are growing in the roots of the social and human determinants of health. This is where the structural and systemic racism and institutional traumas that have been so prevalent across our communities. I mean, I think here we're in Minnesota, you think of communities with African American or Native American, significantly higher rates of trauma and adversity. I have one slide just to keep me honest, that when we talk about trauma, we can get kind of down and in the dumps, but humans are incredibly resilient and communities are incredibly resilient. And so some of the communities that you would think would have higher incidences actually have lower because of the resilience. At the same time, I need to call out and acknowledge that when someone, as an individual, a family, or a community evidences resilience, that means they have first experienced trauma. We cannot evidence our resilience without the trauma. So anytime, especially someone like myself, is speaking of populations being resilient, I want to always acknowledge it with the idea that that means that that person, family, or community has been traumatized. And these are the traumas that we need to get to. If we're going to make an impact on any of what I've shared with you today, we've got to get to those structural and systemic and institutional traumas and abuse. And then the final thing on this infographic is the environment, and that the environment can be a source of trauma and adversity. This infographic predates the COVID pandemic, but called out a pandemic, and that has been a huge trauma. These are just the rates. One of your test questions is, at 4 or more adverse child experiences, there's a 4 or 5-fold increase in depression. You can see there's a 12-fold risk of suicide with 4 or more adverse child experiences. When you get to 6, remember Amy was at 7. At 6, it's a 20-year life expectancy reduction. That's the consequence of not addressing these issues. And then this, I think, is profound. This shows that there's a dose response of more and more ACEs causing more alcohol use, more drug use, more depressed affect. And then at suicide, when we get to 6 or more adverse childhood experiences, there is a 24 times higher risk of a suicide attempt. 24 times higher. So we need to recognize that. What's going on here? Gonna just briefly unpack this. When you see a dose response, and I call it a dose response, why? Because I'm a doc. I work in medications. And when we're studying medication, to really drill down that this medication is truly having an effect that we think it is having, we look for that dose effect, that when we increase the dose, it's more effective, up into the point that it just hits a ceiling. Does that make sense? You can see that with psychotherapies too. There's a dose effect, number of sessions over time. When we see that, it's not just a correlation. The therapy is not just correlated with getting better. The medication is not just correlated with getting better. There's a relationship that's tied there. And so when we see a dose response with ACEs and substance use disorder, depression, anxiety, diabetes, heart disease, what's going on there? And this is one of the ways. Epigenetics. Who's heard of epigenetics, that term? It's the interface of nurture plus nature. Not that it's nurture versus nature, it's both and. And what happens with epigenetics is that genes that were once turned off, see this little pink thing? That's a gene. But when it's coiled up like this, it's off. It is not on. But when something happens in the environment that stretches out our DNA, this gene is now open and it can be turned on. And that gets turned on, gets turned off based upon environmental experiences. So it can be trauma, it can be adversity. It can also be passed on generation to generation if there are those generational traumas. It's not that the genes are changing. It's not that your DNA is somehow changed. It's just turning on which ones get read into the building blocks of our body and brains and which ones get turned off. Does that make sense? Analogy, I'm going to take a moment and do this analogy. If I gave everybody a paragraph to read, and it was a really clear paragraph with one message, and I handed it all out, you all read it, you come back to me, you would tell me a similar message because it's the same paragraph, and I told you to all read the paragraph. Make sense? Now I'm going to take a second paragraph, again, well written, clear message, but for this row, you read every other word. This row, I want you to read every third word. And this row, you got the hardest one. I want you to read every second word, every third word, every second word, every third word. I'll give you 5 more minutes. Now, you guys come back. Those 3 messages are entirely different. Not at all the same. Yet, the paragraph was exactly the same. That's DNA. The words were the same in the same order. Those are our genes. The signal of which ones to turn on and which ones to turn off, that's what's changed. And that's epigenetics. And by doing that, we see real life changes. With chronic trauma in childhood, you can see an increase in the genes that cause inflammation, so that there's chronic inflammation into adulthood. Chronic systemic inflammation leads to a lot of chronic illness, including if it's in the central nervous system in the brain, you can see higher incidences of depression. It can increase our stress hormones. So you can have circulating high stress hormones even at baseline. And individuals like Amy who grew up with that trauma have more hyperstartle, hyperarousal, a greater propensity to get fight, flight, or freeze. And you can see this in the individual. You can see it in family systems who have been high trauma families, and you can see it in populations that have more propensity to fight, flight, or freeze responses. Is that making sense? There are epigenetic factors related to ACEs and trauma that increase it actually changes the sensitivity of our pain receptors. So Amy's pelvic pain, real, not in her head. Her receptors would perceive stimuli that my receptors wouldn't call painful, hers did. That increases the risk of chronic pain, increases the risk of opioid use. And then finally, in brain science, there is a delayed development of the prefrontal cortex. So can you imagine, you have someone who is exposed to drugs or alcohol in their teen years, and they've had trauma, they have even less of that prefrontal cortex. Who has been a parent of a 14-year-old? Who's been a 14-year-old, right? Not the best decisions all of the time. Right? You know, sometimes you're like, what in the world was I thinking? Right? That's what I'm talking about. Now, make it even more delayed so that if there's exposure, there's not that same stop signal. We also have seen that baseline endorphins, those opioids that the brain makes themselves, lower in individuals who as a child had trauma. So as an adult, they have lower baseline opioids. Also, lower or blunted dopamine response to natural rewards. So listen to the person that tells you, through my whole life, I would be looking around at all of my friends and I would see them get so excited and I never felt that. I would look at it and it'd be like, what the hell? And then I used, and it was like, oh my God, this is what they've been, right? I'm seeing the nods. That's this. They're literally telling you what their neurobiology is. They're saying, I likely have a trauma history and my dopamine response has been low and blunted until this moment. Well, that's freaking profound, right? And that's that understanding and that awareness. This I want to bring back. If they've got delayed development of the prefrontal cortex, they're going to be showing this. So let's be patient. Humans are resilient. We got to respect and we've got to be strength-based. We got to look when Amy comes in and says, Doc, man, I'm struggling, but I am starting to see how I was contributing to pushing people away. Oh man, I got to jump on that. And I got to say, that's recovery in action right there. For her to be able to have that self-awareness, that's the front part of the brain. Just seeing Amy with that first appointment, pointing out to her strength for getting to the appointment, for being alive, right? Because she's not seeing herself as strength. She's been seeing, the family's been saying, and society's been saying, you're a failure. But if we see her as the strong person who actually is still surviving all of this, all those overdoses, all those cuttings, all that trauma. So individual strength, family support, friendships, and then the communities and cultural supports cannot be overplayed. And again, that's when we'll build into part 2 in terms of how we can instill and increase this. This is just a very busy slide that says again that if we see increases in oxytocin, it increases trust. The opioids also are part of attachment. touch is critically important. I think back to the days when we were all social distancing. That's not a political comment. It's just factually that when we were socially distanced, none of us were thriving in the same way that we do when we can have human touch. And then positive emotions and treatment can help. Look at this. Activation of the opioid system in the amygdala and the hippocampus, that limbic system, just like we were saying. And then helping and addressing these epigenetic changes for a woman who is pregnant actually has direct impact on their developing infant, and that when the infant is born, they have less stress hormones, which is amazing. Finally, to summarize, we need to all recognize that the childhood traumas that are experienced by the Amy's in our lives. Truly understand the why behind the initiation of the substance use. Then know that the front part of the brain and fight, flight, or freeze were likely not operating in the same way that they would have had she not had those traumas and a substance use disorder. Substance use disorder further changes the brain. Reflect and own our own behaviors. Know that a return to use is actually a reemergence of symptoms, not failure and not relapse. And ensure that everyone, not just the clinicians in the room, but all of us are focused on continuous engagement, motivation, helping people to be adherent. And I leave you with this quote from Dr. Matei: regardless of the pain, challenges, or wounds that we carry, there's always the potential for healing and transformation. Thank you very much. Sorry, 10 minutes. 10 minutes over. Close.
You
Thanks.
got 10 minutes more.
Yeah,
vacation.
okay.
Great.
I'm happy to field questions. I also want to be respectful of time. Where's Jessica? Are there any questions that are pressing? No, they've just all been stunned to silence. Awesome. Yes.
Amazing.
So when you talk about like when they're, that part was stunted or whatever,
Yes. Yeah.
does that ever like grow again?
Great question. So the question is, I made mention of the delayed development of the front part of the brain with trauma and childhood adversity. First of all, that's not universal. That's not everyone who has a trauma history. It's just that we've been in both medical literature and in education. The education systems have been studying this too, because when you see a delay in the front part of the brain, it comes out as behavioral difficulties in school. Because this front part of the brain is what helps us to follow all the rules, sit still, focus, and attend. And so the question in the room was, if there is that delay, does it ultimately develop? And the good news is that for the vast majority, absolutely. Absolutely. It necessitates a discontinuation or a marked reduction in use to start that process, and time. I say that it's most individuals because there are individuals because of other neurodevelopmental disorders or actual head trauma, strokes, TBI. That doesn't necessarily come back. But the vast majority of people, for those of you really working in the field, it's when you see the person come back and they're themselves, and you're like, wow. You're like a different, the moment you say they're like a different person, or you experience for yourself, I'm like a different person, 100%, you've just identified that some of the prefrontal cortex is coming back online. That's like overlapping. Great question.
Thank you.
Yes.
We have one from Rachel that says, with the comment about people engaging in motivational interactions, does that include CD texts, and should they include cognizant trauma and trauma?
Yes. Okay. Love the question. Rachel, was it? Rachel, thank you. I actually planted Rachel for this. No, I did not. I did not, but I love the question. And of course, my answer is going to be yes. Recognizing that it's easy to say yes, and it's much more difficult to actually live that out. But the more that we have anyone who is touching human beings, understanding what we've been talking about today, and understanding some of the tools and techniques that can help people be engaged, the better. And that's across everything. when I was working elsewhere and we were starting programming in St. Paul, there was a pharmacy that was stigmatizing and unmotivating the patients that we would send. And we did not realize that at first, but the people would not come back and we're like, what the hell is going on? And finally, we were able to talk with one of them. They said, yeah, no, I felt completely stigmatized and judged. And I'm not gonna get that medicine. I'm not coming back to your treatment. And we went to the pharmacy and had the conversation and they were appalled. Like they did not intend this, but we are a product of our society. And I will also indict the US health system. It is institutionalizing its stigma across multiple intersections. And one of them is substance use disorder, and others are all the institutionalized racism that still exists. And that is, I'm a product of that. I grew up in that. And so that once we talked to them, they changed how they were interacting and they became actual champions. So it's the first person who's answering the phone. It's the person who's coming in and greeting someone as they walk into an outpatient clinic. And 100%, everyone, again, who is connected to direct care and or direct interaction should have a baseline of trauma-informed training. Ideally, then you go, as you are more advanced, trauma responsive. And so that you're really responding directly to the trauma, not just informed. And again, I'm loading up Ken because he's going to speak to trauma-informed care and what I'm inferring. So love the question by Rachel. Yeah.
We have another one from Alicia that says, how long does it take for the prefrontal cortex to come back?
Yeah, so the question is, how long does it take for the prefrontal cortex to come back online? Super unsatisfying answer because it's variable to the person. Some individuals who had a lot of executive functioning, who they had a lot of pre-existing development of the prefrontal cortex, you can see return within a few weeks to a couple months. For individuals who are still developing that, or for those who really were using heavily or who had some head trauma, it can take months to multiple years to get that back fully online. Literally, I'm thinking of some of the patients with high and long histories of methamphetamine in particular. I will also put in a plug for every one of us to be watching the executive functioning impacts and deficits related to non-fatal overdoses. Because as we keep having hundreds of thousands of them each year, that has an impact on the brain. The brain does not like having any period of time not getting oxygen and glucose to it. And so your patients who are giving you histories of 4, 5, 6 naloxone reversals, be cognizant of that and be thinking about how do I support them, because they might not have that same executive functioning for a longer period of time. Yes.
We have one from Mary that says, is prefrontal cortex development affected by premature birth or by birth to a mother who is suffering from SUD that is active during pregnancy?
Yeah, so the question is prefrontal development impacted by preterm birth and or being born to a biological mother who was using substances at that time? And the answer to both of those is that's possibility. It's not a universal. I can't say a yes, nor can I say a no. Some really preterm babies have demonstrated a delay in the development, not just the prefrontal cortex, but a lot of neurologic development through their development. It does not mean that it doesn't develop. It means that it develops much slower. And in terms of being born to a woman who is using substances, the answer again is both yes and no. Some babies are born to women who use throughout, and there's no evidence of any of the delay. And there are others that do show that. I will say, just from a research perspective, alcohol tends to be particularly concerning. And that has to do with just how many things alcohol impacts. I think we're just on the cusp of studies that are going to be coming out to look at what are the impacts of cannabis. I do not want to get into the politics of cannabis and cannabis use, but as a neuroscience geek, that I have concerns from the perspective that THC cannabinoid receptors are all over the brain. They are far more prevalent than other receptors that other drugs act upon. And I think we need to really fast forward research so that we know what the hell we are doing. That's as political as I'm going to get. Is I'm a scientist. I'd like to have the science running the show, and not finances, economics, and politics. All right. Well, thank you for the extra time. Thank you, all of you who are online. Really appreciate your engagement.
Thank you again, Dr. Delisi. Thanks to the folks at YourPath, Shelley, Jordan.